Welcome to the Module 4 review. We'll be going over vital signs, scene size of patient assessment, and pharmacology. First, we're going to get into vital signs and monitoring devices. So the first thing we're going to look at is going to be respirations. We want to make sure that we're looking, listening, and feeling, looking to see if we see chest rise and fall, listening to hear if we hear any type of breath sounds, and feeling if we feel any air movement. Feeling also refers to palpating their chest to see if we see any type of injuries or crepitus in the chest area or instability in the chest wall. Um, the main things we're looking at with respiration is going to be our rate, our quality, our rhythm, and regularity. So for rate, as you can see on this slide, there's the different rates for the different age groups. Make sure that you're familiar with this whenever you're going over this in your book. But for rate, we're looking at how many breaths is my patient taking in 1 minute. So I'm going to count breaths for about 30 seconds, and then I'm going to multiply that by 2. So a patient that breathes 10 times in 30 seconds is going to be a respiratory rate of 20. Next, we're going to be looking at our patient's quality. Next, we're going to be looking at our patient's quality, right? Quality is strictly referred to tidal volume. We're looking at if it is it normal, is it shallow, is it labored, or noisy. For our shallow breathing patients, we want to make sure that we're ventilating them. If it's labored or noisy, we're going to treat those accordingly, right? For the labored ones, we may put them on a non-rebreather. If it's affecting them deeply, we may even bag those patients also. Noisy respirations, we want to notate because that's going to possibly tell us what medications or other devices that we may need to use for these patients. Lastly, we're going to look at our patient's rhythm, and it's going to be talking about the interval at which they're breathing. We want to look to see if it's irregular. There's a couple of different rhythms that they may have that's kind of typical for our patients. It's going to be Cheyne-Stokes, Biot's, apneustic, ataxic, agonal, Kussmaul, and central neurogenic hyperventilation. So make sure that you're familiar with all of these and what conditions cause these different types of rhythms. Next, we're going to kind of talk about our pulse assessment. So big thing with assessing a pulse is depending on our patient's age and their level of responsiveness, the location that we go to assess the pulse is going to kind of change. If our patients are under 1 year old, then we're going to go ahead and check their brachial pulse. And if our patient is an adult who is awake, alert, and oriented, we want to kind of go for that radial pulse. If our patient is unresponsive, then we'll go for the carotid pulse. Whenever we're checking pulse, it's very similar to when we're checking respirations. We want to look at rate, rhythm, and quality. Rate is the exact same way for respirations. We're going to count it for 15 to 30 seconds and then multiply by 4 or 2 accordingly. Rhythm, we're looking to see if it's a regular rhythm or if it's an irregular rhythm. And we're going to notate that to pass that information along to a nurse or doctor or even a paramedic that may be intercepting a call. Lastly, we're going to be looking at the quality. Is it strong? Is it bounding? Is it thready? Is it weak? These things kind of let us know what's going on with our patient and give suggestions about what their blood pressure may be. For instance, if they have a weak pulse, we know that they're probably not perfusing well and they're probably hypertensive. So the last thing I want to make sure you guys go over is looking at the different rates for the different age groups. Make sure that you notate these. That way you can know if your patient's pulse rate is within a normal range. Next, we want to be looking at skin signs. We're going to check color, temperature, and condition. For color, we're going to be looking at if our patient's skin is cyanotic, if they're showing signs of jaundice, if they have mottling. So make sure that you go over these different colors so that and understand what each of those mean. One thing to note is that if we have a patient that is of darker skin color, that we may have to check the nail beds or their mucosal membranes in order to get a better idea of their skin color. For temperature, we're going to be checking to see if our patient is cold, if our patient is hot, or if they're just warm, like a normal skin temperature. Lastly, we're going to be checking condition, and that's going to be referring to if they're diaphoretic, if their skin is dry, if their skin is clammy. So make sure that you go over the different types of conditions that the patient's skin could be, and then also make sure that you're notating what these different colors and conditions could potentially mean. Lastly, something to kind of keep in mind with the skin is we check for cap refill, especially in our pediatric patients, because it can indicate low blood pressure and it is a more effective means of figuring out if those pediatric patients are properly perfusing. We want to aim to have our patients to have a cap refill of less than 2 seconds. This slide is a continuation of what I was just talking about. It has all the different colors, temperatures, and conditions that a patient's skin may be in. So make sure that you go over this table inside of your text and use it to help you understand what each one means. Next, we're going to kind of be looking at pupils, right? So it's really easy to check pupils. We're going to just take a pen light, shine it into our patient's eyes, and watch for the reactivity of the pupil to the light. Normally, we would expect the pupils to constrict at a fairly rapid rate. That is going to be pupils equal and reactive to light. Whenever we're assessing pupils, we want to be looking at size, equality, and reactivity to light. So size is going to refer to if our patient's eyes are dilated or constricted or somewhere in the middle. Each of these can indicate different things, right? If their eyes are dilated, it could indicate that the patient may be in cardiac arrest, in which case it may be fixed and is going to be fixed rather, and it's not going to react to the light at all, or it may indicate that they're on some type of a drug. Same thing with constricted pupils. It may indicate that they're on some type of a drug, specifically opiates. Um, Next, we're going to be looking for equality. We want to make sure that the eyes are equal. As you can see in the last picture, that patient's eyes are not equal. One is one is dilated, and then the other one is constricted. So for this patient, we know that they may have some type of a brain injury. Lastly, we're going to be looking at reactivity to light. There are occasions where the patient's eyes react rather slowly to the light being shined in them. We want to make sure that we're notating that because that can also indicate some type of brain damage or nerve damage. Now we're checking blood pressure. With blood pressure, make sure that you go over the different ranges of blood pressures for the different age groups. Most specifically, you definitely want to go over what blood pressure is too low. We're normally referring to systolic blood pressure when we're looking at that. So for adults, blood pressure under 90 is going to be considered hypotension. Couple things to note whenever we're taking a blood pressure is that we want to try to get our patient to an environment where we have less noise if we're going to be using the stethoscope in order to take the blood pressure, as you see in the picture. If we are, for instance, in a noisy environment, then we can still get a blood pressure on our patient, but we'll probably have to palpate that blood pressure. Um, a couple of the things to note is that if we're checking pulses, remember earlier we were talking about the different quality of pulses. If our patient's pulse is weak, it can indicate that our patient's blood pressure is low. So kind of keep that in mind. We can look at other things to help us kind of figure out what the blood pressure may be before we even get to taking a manual blood pressure. Another tool that we have that we can use to assess blood pressure is going to be our tilt test. Remember how I said taking a blood pressure is a great way to figure out if our patient is perfusing well or not. This tilt test goes a little bit further with that. For our patients who may have passed out previously, we can go ahead and assess if low blood volume is the reason why they passed out. So what we're going to do is have our patient lay down, sit up, and stand up, and we're going to assess their blood pressure in these different positions. We're also going to be assessing their pulse rate. If their heart rate increases somewhere between 10 or 20, then we know that that's a positive sign. Also, if their blood pressure decreases 10 or 20, that's a positive sign. So make sure that you use this if your patient is showing signs that they may be having low blood volume. Also, something to keep in mind when you're doing this is to go ahead and have somebody there to support your patient when you get them standing up. Like we said, these are patients who probably had some type of a syncopal episode or passed out. So we want to make sure that we have somebody there to support them in case they start feeling woozy or dizzy. If they do, just allow your patient to sit back down and get their bearings before continuing on with your assessment or treatment of the patient. Another tool that we have at our disposal is our pulse oximeter. It's going to be measuring the amount of oxygen attached to the hemoglobin in your blood. Um, this is a great tool to kind of assess if our patient is oxygenating properly. But some kind of things to keep in mind whenever we're using the pulse ox is that it's not just measuring oxygen attached to hemoglobin, it's measuring gases attached to hemoglobin. So if they have carbon monoxide, for instance, if they were in a fire, or if they have carbon monoxide poisoning from some type of a gas leak or something inside of the house, it's also going to show a high reading. We want to make sure that we're also keeping in mind that if they have fingernail polish on, if they're cold, they're also going to show inadequate readings on the pulse ox. If the patient is shunting for any reason to their core, um, like I said, if they're cold, but also if they're hypotensive, meaning that they're not going to be perfusing peripherally and all of their perfusion is going to be centrally, it's going to give you a wonky SpO2 reading. So kind of keep that in mind whenever you're assessing. For the pulse ox, we want to make sure that we have a reading greater than 94. If the patient's reading is 94 or less, we want to be trying to oxygenate these patients. And based on their other signs and symptoms, we'll determine which device that we'll be using to oxygenate them. Some of the other monitoring equipment that you may come across is going to be capnography or 12 lead ECG. So first let's talk about capnography a little bit. Capnography or end-tidal CO2 monitor is going to be measuring the amount of carbon dioxide that's being exhaled. It can come in the form of a nasal cannula, or it can attach directly to your supraglottic airway or your BVM to measure how much carbon dioxide the patient is pushing out. Um, Also, we have our 12 lead ECG, and you have 4 limb leads that go on the right arm, right leg, and left leg. And then when you add the additional 6 chest leads, that makes it a 12 lead. I know it adds up to 10, but trust me, it's 12 different views of the heart, and that's why it's called a 12 lead. That's going to be monitoring that electrical activity of the heart. And these two tools you'll be utilizing whenever you're working with a paramedic and you have that Life Pack 15. You'll attach these to the patient, and it will give your paramedic partner some good information about what's going on with the patient and where you guys need to go with your treatment of the patient. Last but not least, with our monitoring devices is going to be our blood glucose monitor. So this one is pretty simple and straightforward. For this one, make sure that you go over this scale and how to um, get the blood and put it on the monitor so that you can get a good blood glucose reading. For this one, our normal range is going to be between 70 and 140. If a patient's just had a meal, that's when it's going to be more in that 120 to 140 range. But normally we'll expect it to be more like between 70 and 100 if they haven't had anything to eat recently. Any numbers higher than 140 is going to be kind of going into that pre-diabetic or diabetic range. So just kind of keep that in mind. For our patients, if their blood sugar is less than 60, at that point we'll start treating with oral glucose. And if you're working with a paramedic partner, they can also give the patient dextrose or give the patient glucagon to help get that blood sugar up. One thing to note is we definitely want to get a blood sugar on every patient that has a altered mental status, especially our stroke and our seizure patients, because low blood sugar levels can definitely cause stroke-like symptoms or cause the patient to start having seizures.